This program is brought to you by Accelero Health Partners. Welcome to the Accelero Advantage Education Series, advanced thinking to keep you ahead of the competition.
There's no question that over the next 5 to 10 years, cost savings will need to occur within healthcare without sacrificing the care of the patient. With that in mind, payers, and particularly the federal government, are projected to roll out several new payment methods over the next 5 years. Our goal in these payment presentations is to provide you with important information in 3 key areas: bundled payment methods, accountable care organizations, and the transformation from what has mostly been a pay-for-reporting model to pay-for-performance. The goal of this session is to provide background information on bundled payment methods. This table provides an overview of healthcare reform, accounting for the cost of providing health coverage to more individuals at a cost of $940 billion, as well as some of the areas of additional revenue and spending reductions to offset the cost. Part of these cost reductions are from changes in Medicare payment rates and methodologies over the next 5 years. 2 of the most talked about new payment methods are accountable care organizations and bundled payment methods. We will be discussing accountable care organizations in subsequent presentations. In summary, accountable care organizations are a broader payment method in which a defined population of patients is cared for across all of their healthcare needs. In comparison, a bundled payment is a set payment for a defined episode of care. It moves the payment model from a fee for each individual test, procedure, or doctor's visit, which is essentially a fee-for-service model, to a single payment for a defined episode of care. A report from the Commonwealth Fund estimates very large healthcare savings with the implementation of bundled care payments. Since this payment model is more procedure-based, orthopedics and specifically total joint replacements will be on the radar for testing these payment models. There are a high number of total joint replacements performed in this country. The overall healthcare cost in aggregate is high, and relatively speaking, they have a low amount of variability in their care. All of these factors make total joints a targeted population for bundled care methods. While there is no global bundled payment model as of yet, we can gain some insight as to what the future might bring based upon examining 2 current pilot projects that involve bundled payment specifically for total joint replacements. We'll start with the Medicare Acute Care Episode, or ACE, demonstration project. In a traditional Medicare model, payment is made to the hospital for their portion of the services, the Part A portion, and to the physicians for their portion of the services provided, Part B. Bundled payment essentially pulls both of these components into a single payment. By the nature of the process, hospitals and surgeons will need to align in order to improve efficiency and decrease cost while improving the patient's care. As mentioned previously, based upon the high number of joint replacement cases and the relatively low variability in care, it became one of the 2 focus areas for the initial ACE pilot projects. In this pilot project, which began almost 2 years ago, Medicare limited their demonstration pilot to just 1 geographic area. While several sites placed bids for this pilot project, 3 were chosen: Hillcrest Medical Center, Baptist Health System, and Lovelace Health System. The orthopedic episode of care in this project was defined as only the hospital stay. There is something to be learned from understanding the bidding process that took place in this pilot project. In this model, you can see that the hospital traditionally got paid $11,080 for the joint replacement procedure, and the orthopedic surgeon got paid $1,456. Other consultant fees totaled $964 for a grand total of $13,500. In this model, the bidding hospital proposed to Medicare that they would accept a bundled payment of $12,700 to be part of this ACE pilot project. Therefore, there was a savings of $800 for each case. In the pilot project, half of the payment was returned back to the patient for their participation in the project, and Medicare kept the remaining savings. So in this model, the hospital takes on more risk of managing the patient. The hospitals believe that at a minimum they could decrease costs by at least $800 per case by working collaboratively with the surgeons. The main areas of cost savings are focused primarily around supplies and implant cost, operational efficiency such as reduction in complications and better management of length of stay, along with better management of testing and diagnostic procedures and consults. Essentially, this pilot project also gives Medicare some idea of how much costs can be taken out of the system, thereby possibly laying the groundwork for further fee setting. So why would a physician participate in this pilot project? First, there's no risk for them since the guidelines for this project allow them to recoup their current Part B payment. Second, as part of the pilot, Medicare is allowing surgeons to gain additional payment based upon a gain-sharing model. They are eligible for up to an additional 25% of their normal Part B payments. In this example, for a busy joint replacement surgeon doing over 700 cases, that equates to $375 per case, or over $250,000 of additional payment over the year. That gives substantial incentive to a surgeon to work collaboratively with a hospital to reduce cost. So why would a hospital take on the risk and participate in this pilot project? The biggest reason is that by participating in the project, a hospital can market and promote themselves as a value-based care center. This designation should provide them differentiation in the marketplace and hopefully additional case market share. Two of the hospitals that are part of the orthopedic pilot project have advertised on their hospital's homepage their involvement in this project. They specifically highlight how a patient can save money by participating in the project. These Medicare bundled payment projects are slated to end in 2015. In general, Medicare waits for a pilot project to end before determining next steps. It is too early to determine if market share is increased for hospitals involved in the pilot project or if gain-sharing distributions to surgeons have occurred in a meaningful way. Remember, this is only a pilot project and the guidelines for broader implementation will most likely be different. It is anticipated that in broader implementation, there will be no payment back to the patient, and the definition of the episode of care will most likely extend to include a 90-day post-discharge window. Also, as part of healthcare reform, it is likely that another round of pilot projects will occur in the next 2 years with different implementation strategies. These are most likely the next steps before a more global implementation strategy of a bundled payment method. In addition to the Medicare ACE pilot project, there is a second bundled payment pilot that is worth reviewing. This project is a non-Medicare project that is occurring in California. The Integrated Healthcare Association, IHA, is a statewide group in California that promotes healthcare quality improvement. They received a grant to launch a pilot project around a bundled payment model with the goal of improving efficiency, generating cost savings, and improving outcomes. As expected, based upon what was discussed earlier, IHA chose total joint replacements to be the first group of surgical procedures to focus on during their pilot project. You can see that a number of hospitals in Los Angeles and Orange County have volunteered to participate in this project. Also, a variety of payers are involved in the pilot. No different than the Medicare bundled payment pilot, this project is designed to lower cost while improving care. The method to accomplish this carries a similar theme of physician and hospital collaboration. It also actively involves the health plan. Different from the current Medicare pilot project, the IHA project extends the definition of the episode of care to include a 90-day post-discharge window. Therefore, the bundled payment in this pilot project would take into consideration the cost of readmissions due to complications and in some payers different elements of the post-acute care. This includes both rehabilitation and nursing care, whether it occurs as part of home health care, inpatient comprehensive rehabilitation, or outpatient physical therapy. Providers therefore must understand their current cost on a much wider care continuum as compared to the Medicare pilot project. Since the definition of the episode of care extends to many providers, there will need to be an agreement among the providers. For this to occur, either a hospital or an independent physician association, IPA, can serve as the contractor. Their role as a contractor is to build this network of providers and create a method to understand the cost and frequency of use for each provider, along with having a method to disperse the bundled payment appropriately to each provider. As mentioned previously, the negotiated reimbursement for the episode of care will be based upon historical cost and utilization. This must be known by the providers to effectively negotiate the contract. Similar to the Medicare Bundled Payment Project, provider gain sharing from cost savings is part of this project, with methods in place to ensure that quality is not sacrificed during the process. Now that we have looked in depth at a few bundled care pilot projects, let's summarize what they will mean. First, the pilots presented are just that. They're pilots. Future implementation of actual more global methods will most likely be similar in concept, but different in actual detail. Those key concepts are the following. Orthopedics, and specifically joint replacement, will most likely be part of the early implementation. The defined episode of care will most likely extend to a window of time post-hospital discharge. And finally, some amount of gain sharing will most likely be included to drive surgeon participation in cost containment. More than ever, hospitals will need to understand their cost in all areas. Implant cost will be first on their list. However, cost containment can also occur through a number of other methods: improved length of stay management, decreased pathway variability and the associated cost with that, along with decreased clinical complications and understanding the better coordination of post-acute services. All of these are critical elements of service line management and have easily identified solutions. All of this will drive more hospital-surgeon collaboration. The most important concept is that we will need to be involved in these processes, both in the form of fair and reasonable implant pricing, but also in other cost management and process improvement methods. Bundled payment will most likely be a broader payment method in the future. It is important to understand what it might mean and begin preparing for this important change now.
Thank you for attending today's program. For more information on this and other Accelero Advantage programs, contact your designated Accelero team member or visit our website, accelerohealth.com.